Hey, Janet Sperling, and welcome to the Tick Bootcamp podcast.
Thanks for having me.
Well, we're really blessed to have you, and I know our listeners are going to be really excited to hear all of the powerful stuff you're going to teach folks on how they can improve their lives. So let's begin with your background. You're one of the nice North Americans, I understand.
Indeed, yeah.
So you're in Canada. Am I pronouncing the name of your country correctly? Do you have another way of pronouncing Canada?
I think I'll go with Canada. Yeah.
All right.
I
So
I will well, I will tease you just a little bit. That when we lived in California, whenever I said the letter A, like apple, people would keep saying, "Well, why do you keep talking about apples? Like what's an apple?" And the other one that would catch people was a boat. I would
a
say,
vote.
I
let's
love
go.
that.
And they're saying, why do you have this hang up on boots, right?
Yes. That's one of my favorite thing about Canadian hockey players. They always say boot. All right. Thank you for taking some time away from being one of the nice people living in one of the nice countries in North America and joining the cranky North Americans out here in
Yep.
America. Talk to us a little bit about your background. Where'd you grow up? Where'd you go to school? What's your background?
Sure. So I grew up in Edmonton, Alberta, so sort of Western Canada, and I went to school to the University of Alberta, which was my local university. I started off studying plants, which I found fascinating, and particularly like growing potatoes and things like that. So unfortunately, that's when I was first introduced to the idea of insects as pests. I enjoyed my insect pests with the plant pests so much that I ended up taking entomology as kind of the big part of the degree. And of course, there we learned about medical entomology. And medical entomology is where I first learned about Lyme disease. And I said to myself, I studied for the exam, I got all the right answers, I got a really good mark. And I thought, oh, this is pretty straightforward. There's a tick and there's a bacterium. And I just memorized the name of the tick, I memorized the name of the bacterium, and it's pretty straightforward. But I didn't think I needed to particularly worry about it. I thought, it's one of these rare things that happens.
Now, was this the study in Canada? Was this at the undergraduate level, the graduate level? Where were you in your educational journey?
At that point, undergraduate. And then after that, I went off and I did a master's in entomology. And that was actually on potato beetles, the sense of taste. Like, why does a potato beetle eat a potato and not a weed? And I was comparing different species to see if we could see what was happening at the level of their little chemoreceptors. So that was my master's. I met my husband, who was doing a PhD. He studies these beautiful butterflies, papilio butterflies. We got married. We had 4 boys, right? So, it all went well. And then my husband works full time as a professor. And then I just take contracts when it comes up.
Okay. So it sounds like you're a real nice little geeky family studying bugs and just enjoying life. So let's talk a little bit more about ticks. I'm interested that ticks were a part of your entomological, am I pronouncing the word right? Studies, because ticks are not insects, right? They are. So it's always interesting to us that most of the people who are studying ticks are people who didn't really study ticks. They were studying insects, and most people think ticks are insects. So give me that crossover. Like how did ticks make their way into your study, even though you were studying insects?
Well, when you study entomology, we study a very kind of broad idea that you're talking about anything that can do with an insect. So the emphasis is an insect. Often they're in a department where they study insects, they study nematodes, which are not insects either, but ticks are kind of grouped in with that. And I think it sort of goes back to the idea of a pest species. And that's why people are putting them together. And then when I first took the course about medical entomology, we were told that the ticks basically didn't come up to where I am in Edmonton, that they kind of stopped maybe 150 kilometers farther south. So if I went into the mountains, I might need to worry about a tick. If I went over to Manitoba, might need to worry about a tick. But basically, I didn't really think about ticks in my own backyard.
Well, you anticipated my next question because I thought it was interesting that you would be studying ticks in Canada, right? And certainly in I guess Western Canada, where there would likely be the belief that there would not be many ticks there. I mean, we certainly have a different perspective here at Tick Boot Camp about where ticks are. We think every community is a tick endemic community, and we certainly think all of North America is tick endemic, but that's certainly not, I think, the standard educational belief. And I just thought it was interesting that you were studying ticks in Canada. So now let's talk about the medical element of your study. Why was it called medical entomology? Is it because you were studying how ticks could make humans sick, or is it something else?
Yeah,
Or I
it's
guess
basically
insects.
sure. It's one step back, so it's insects. When you take a look at sort of human evolution, mosquitoes and malaria are huge. So we spend a lot of time learning about mosquitoes and the different types of malaria and how it's transmitted. We also learned that there is such thing as mechanical transmission and biological transmission. So mechanical transmission is you have a disease agent, and then the insect is going to bite you. Maybe it's a horsefly, something like that. It's going to bite you and deposit the disease, which then can affect you. That's not anywhere near as efficient as the biological transmission. So that was something that was really brought home to us. We learned about viruses, we learned about bacteria, we learned about, all sorts of things can be transmitted. And then ticks are known to transmit the greatest variety of these various diseases. So they were always considered to be very important.
Okay, so write down that it's interesting. It's always great to meet new people and learn very early on. So I don't know, and Matt, you can help me with this. I don't know that anyone's ever made the distinction for us between mechanical and biological transmission. So
No.
so the mechanical is there's just a deposit, meaning it's, I guess, left there, and it seems to me that would certainly be a lot less dangerous. And then the biological, and let's focus on ticks now, where we have the tick that's inserting its mouthpiece into its host. It has all kinds of very interesting properties which I'd like to develop with you. And then there is this exchange between the tick spitting into the host and the host blood coming back to the tick. So that's the biological process as opposed to the mechanical process.
Yes. And then also with the mechanical, basically you would have maybe 10 viral particles and they would go down. You might scratch them into your own skin. Sometimes that's what the insect does, is it creates a wound, you end up spreading it into yourself. But the biological one is where it actually uses the vector to help multiply. So for example, with a tick, the bacterium, the Lyme disease bacterium, is in the midgut of the tick. And it has special proteins it's going to latch onto. And then when the warm mammal blood comes along, because the tick will be basically room temperature, then warm mammal blood comes in, it's 37 degrees. The bacteria says, wow, time to get moving. So now it's going to go from the midgut to the salivary gland. And that's important because if it only stayed in the midgut, it wouldn't be that big a deal.
The
But
midgut of the tick.
yeah, exactly. From the midgut of the tick to the salivary gland of the tick. And then with a mosquito, for example, it will inject the virus and then it'll leave. But in the case of the tick, it's going to drive its mouth parts in. It's going to wait. It's going to cement its mouth parts in this particular case.
I mean, it's unbelievable that they have this property where it cements into the host. It's wild.
It's wild, yeah.
Yeah.
And then it circulates this. So even supposing I had a tick, it attached, and I took the back end of the tick off, but I left the mouth parts in, that wouldn't be such a big thing. That would be like a raspberry prickle or something like that. You'd reach over with your tweezers, you'd pull it out. The problem is the tick is really good at finding places where it doesn't think you're going to find it. So it's going to sit there, and then over days, it's going to keep doing this cycling. And then if you didn't get it in the first hour, the chances of getting it go up over time.
So some of the reasons why we at times debate with guests on the podcast about whether or not the ticks are just the best at transmitting the disease or really the only vector that can transmit the disease. And again, and I do want to have a conversation with you about how we define Lyme disease, but let's bookmark that for a second and stay with the first focus that I'd like to talk with you about is that the length of attachment is significant in the likelihood of you getting the disease, right? So, there are folks that argue that you can get Borrelia from a fly, or you can get Borrelia from a mosquito. And my argument in most cases is no, you can't, even though the bacteria may be in the fly or the mosquito. The length of attachment is not long enough for the disease to be transmitted. Give me your reaction to that.
Okay. I'm going to give you a really mushy, nailing jello to the wall kind of response. I'm
Okay.
going to say that if you showed me that somebody had a biting fly, so one of these horse flies, a deer fly, something like that, and they got Lyme disease from that fly, I would say, yeah, I bet you did. Now, it's less likely, hugely less likely. But supposing that fly had gone over and it had taken a host, they take their little mandibles and then they slash, they cut like two little knives, and the blood wells up. If they had the blood and then they came over and they bit you just a couple of minutes later, I would say it's possible. Now, it's much less likely. So there's no question that it's not as common as the tick. The tick and the Borrelia have co-evolved over a long time. So they've just got it down to an art. But mechanical transmission can happen. It's much less likely to happen.
Okay, so let's talk about the difference because again, you've already blessed us with this distinction that we had not heard before between the biological and the mechanical, and it's going to really help me with my, how I think through this. So one of the challenges with now the mechanical process is that you do not have length of attachment. You don't have the properties in the spit which will act to suppress your immune system. And then you don't have the same volume of the bacteria being spit into the host as you would if you had the mechanical transmission. And at least in
The
our
biological transmission.
no, no, the biological transmission has a much larger volume of the bacteria coming in as opposed to the mechanical transmission where you're not going to have the same volume. So when you have this distinction between a mosquito, for example, or a fly, or maybe even a flea, even if they were to harbor the bacteria, because the transmission is mechanical, there are many other properties to the tick transmission, not just because of the co-evolution between and the relationship between the bacteria and Borrelia and the tick, but it's also the properties of the vector itself, the tick itself, right? Because the way the tick is now not only piercing the skin, cementing itself into the skin, spitting into the skin, and spitting into the skin with properties that have anticoagulation properties. So you have no blood plug, right? You have immunosuppressive properties. So you don't have the immune response that you would have to this mechanical transmission. You also have a large volume of the bacteria being spit in, which you're not going to have with the mechanical transmission. And the other piece that you just explained to us, which is now the blood is now coming into the midgut of the tick, and there is a protein exchange between the host blood and the vector, which now when the Borrelia gets spit into the host, it's even more difficult for the host immune system to respond to it because some of the protein properties from the blood itself are a part now of the Borrelia. So when you're putting together that whole biological process, It just seems to me that the mechanical process from a fly or a mosquito is just simply not going to result in a Lyme disease outcome.
I'm going to say unlikely, less likely, but I'm still always going to leave myself that little piece that says, I think it's possible. But the other thing to keep in mind with a tick, unlike a mosquito, like when a mosquito comes in, pulls the blood out, it poops out the liquid part because a lot of blood is liquid, and then it can fly away. The tick doesn't do that. The tick takes it, it shoots it back into you. So there's this kind of constant cycling going on with the tick.
Right. So, I mean, the other piece of it is, though, is that your immune system, which is, we've been getting bitten by ticks. I'll use the Dr. Roll's quote. We've been getting bitten by ticks as long as we've existed, right? Humans are getting bitten by ticks as long as there have been humans, right? And Borrelia is not a foreign, microbe from our immune historical standpoint. Meaning we have software that allows us, again, assuming the bacteria has not been altered, and we can go down that rabbit hole too from the standpoint of whether it's been weaponized. But our immune system is familiar with Borrelia. It is. And okay, let me finish the argument, and I'll love to hear your response. So I really believe that if you don't have the immunosuppressive properties of the tick spit, that it's very likely that if you have this mechanical transmission, that our immune system is going to kill the bacterium before it can take off and before it can make us even acutely ill.
Correct. Now, I'm going to say that Borrelia, so Lyme disease, is actually a zoonotic disease. We're a dead-end host, right? So we haven't actually had a lot of selection pressure for it. So this is not like malaria. Malaria, we've got a lot of selection over many, many generations. The Borrelia is just every once in a while, unfortunate circumstance happens. So that definitely is part of it. I'm still going to say that it is possible. And an example would be you could have a organ transplant, you can have maternal fetal transmission, you can have a lot of things that are not just the tick. But without any doubt, the tick is the most efficient, which is why we put so much effort on avoiding the tick attachment. And if you avoid the tick attachment, you're avoiding Lyme disease, you're avoiding a lot of viruses, you're avoiding a whole lot of other things. So just like don't let yourself get bitten by mosquitoes, don't let yourself get bitten by ticks.
Yeah, and don't allow the tick to, if you're going to be bitten by a tick, make sure you're checking yourself regularly and checking yourself properly, because if you do that and you're limiting the amount of attachment time, you're significantly reducing the likelihood that you're going to become ill from the disease, or ill from the bite, right? So it's certainly avoided in the first place, but even if you haven't been able to avoid it, we can still interfere with the pattern of illness if we ultimately check ourselves and remove the tick properly. So
Absolutely.
so let's come back to one of the questions that I asked you about earlier, or a tease that I was going to ask you about earlier with the bookmark, which is how do you define Lyme disease? Because one of the things that we have discovered over the 5 years we've been doing this podcast is there seem to be as many definitions of Lyme disease as there are experts who are working with it and studying it. So I know you have a strong scientific background, and you're probably going to have a much tighter channel than maybe some of the influencers are. But give me your definition of Lyme disease.
Okay. So Lyme disease is a bacterial infection with Borrelia, and there are many different species in that group. So you call that sensu lato in the very broad sense. So that's Lyme disease. I would go as far as to say, as a person, you're going to look at Lyme disease and you're going to say, maybe it's not exactly Lyme disease, but it's something close. Okay, so in a case, I'm willing to say from the point of view of the human, you don't care if it's exactly Lyme disease or something like Lyme disease. So The
Okay.
other thing is when we talk about just Borrelia being, Borrelia and then multiple different types, Afzelii, Guerinii, Burgdorferi, of those, they have to actually cause an effect on the human. So I'm going to go as far as to say there are some people who may actually have a positive immune response to Borrelia, but they never get sick. So if
Right.
they're not sick, they don't have a disease.
Right. Okay. So you're restricting your definition to one bacteria and its various strains of the bacteria and the human response to that strain or strains of the bacteria.
Yeah, multiple strains. Yeah.
Okay. Let me give you our definition of Lyme disease, and I'd like you to react to it. So we define Lyme disease as a polymicrobial, multisystemic, chronic or post-chronic, chronic infectious or post-infectious disease. What would your reaction be to our definition of Lyme disease?
I'm good with that, actually. I think, again, from the point of a human, you don't care. Like, if you can show me later on that it was rickettsia, it was a co-infection, I'm good with that. So I do understand that some of the tension is if you're only looking for Lyme disease, you won't necessarily find it because some of the people are actually sick with a different bacterium, but you give them the antibiotics,
Or
they get
virus or
better.
protozoa, right?
Oh, yeah, 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 yeah.
So, let's break it down. I'd like your reaction to each piece of it. So the first part of our definition is it's polymicrobial. And what we have come to understand based on our, I don't know, Matt, over 600 interviews that we've done
Yeah.
online and certainly, maybe another 10,000 offline, that very rarely does somebody have a diagnosis of one strain of one bacteria. That generally, and again, I'd like your reaction to this, just in the same way that the tick or the vector has co-evolved with Borrelia, it seems that Borrelia has also co-evolved with many other microbes, and that they seem to be dogpiling on the host together. And so we keep seeing, and we're seeing this with increasing frequency. And I don't know if it's because it's changing within the ticks or our ability to test is changing, but we almost uniformly see at least the three Bs, where we have Borrelia, Bartonella, and Babesia at the same time, essentially working together to suppress the immune system of the host and ultimately cause the chronic illness. So that's one of the reasons why we bring the polymicrobial element into this, because we just see a whole group of microbes working together rather than one microbe together. So give me your reaction to that piece of it based on your observations, not just as a scientist, but also as an activist.
Yeah. So the first thing I think of is it's sampling bias. There have to be people who have only Borrelia. Remember, there has to be a disease associated with this. So you might have other bacteria, but if they aren't making you sick, it's not a disease. So I would say probably most people have Borrelia. Those are the people, they go to the doctor treats them with the antibiotic, they get better. We never hear from them again. They're fine. They go back to work. So that's the selection bias, where the people who remain sick are the very unfortunate people who either they had a tick with all of those things at the same time, or they had multiple tick bites, or maybe they had a flea bite. They could have got the Bartonella from a flea. They
For
could have
sure.
got it from a
For sure.
cat scratch,
For
right?
sure.
The human that you're looking at, you have to look at that individual human. And that individual human, of course, has its entire history. And the immune system of that human has its own history too.
Yeah, I mean, you're right. There are so many permutations here, and I'm already enjoying the rabbit holes that we're going down. I could take you down so many more, but let's stay at this level for the purpose of our conversation. So, your argument is that you believe that there are some people who become chronically ill just by having one strain of one bacteria. In this case, we're defining Lyme for our conversation as Borrelia. I don't define Borrelia as Lyme disease. At least Matt and I don't. So we're calling it polymicrobial, and I guess your argument is it could be polymicrobial, but it doesn't necessarily mean that it's from a single tick bite, right? It could
Right.
be you have this human who has had all these experiences and getting scratched by a cat, getting a flea bite, and your immune system is managing those microbes, and then they get bitten by a tick, and they get bitten by a mosquito, and they get bitten by another tick. And what's happening is each time they're having this exposure to the various vectors, the immune system is managing it and managing it and managing it, and then it can't, right? And that's where the chronic illness comes in. I think that's an important distinction on the polymicrobial piece, whether or not it's one vector, more than one vector, one tick bite, but you do have this whole history, which is an important distinction. But let's talk about now the multisystemic piece of this. In our definition. What is your reaction to Lyme disease having to be multisystemic?
I think in the worst cases, that's the easiest explanation.
Well, how,
So I think that most often, if you have, for example, Babesia, and you give somebody antibiotics for Lyme disease, that's not doing anything. It's a different beast. So
right.
you have to treat it differently. So I think that of the complicated cases where people don't get better right away, I would look first for co-infection. And you look for co-infection with one of these other things. And if you find that they have the other things and you treat them for that, maybe you then have to go back and treat for the Lyme disease. That's where it's so difficult, that you need a doctor who's willing to look at that individual patient and say, for this individual, I think, the Borrelia is most important. Or maybe for this individual, the Babesia is the most important. And if
Okay.
we treat one, then we can treat the other. Maybe you can treat them both at the same time. But these, again, are complicated problems, and we need well-trained doctors who look at the response of the human and say, well, they got better. We gave them combination antibiotics and they got better. We think it was, and then you list the types of things, often Bartonella and Babesia are very commonly associated with people who are sick with Lyme disease. Yeah.
Okay. So again, and part of the reason why we're aggressive about promoting our definition of Lyme disease is because too many medical professionals are trained to look for a single strain of a single bacteria, right? So they're not even open to looking for the co-infections as you're defining it, because it's not a part of their very definition of the disease. And because it's not a part of the definition of the disease, I don't need to look for it. Whereas we argue that if you take the polymicrobial piece of this, it makes it substantially more likely that from a diagnostic standpoint, from a clinical diagnostic standpoint, they're much more likely to help the patient because they're now broadening the scope of their inquiry, the diagnostic inquiry to many, many more microbes. So now the multisystemic piece of course, is also, in our view, an important part of the definition because in many cases, patients are gaslit because they have they have different symptoms in different parts of their body at different time, right? The whole migrating symptom part of Lyme disease, which in many cases, again, because of a bad definition for the traditional definition of disease, what doctors are thinking is that somebody is now malingering when they're coming back at different times with different symptomology and different. Whereas under our definition, when you start to see this multisystemic disease, and you have these different symptomology at different times, that now should bring you to a potential Lyme disease diagnosis, right? So that's why we're on these first two pieces. Let's talk about the next piece of our definition, which is chronic infectious disease. We do not believe an acute infection is Lyme disease. We believe you can have acute borreliosis, for example, or acute, anaplasmosis or acute babesiosis, but we do not define that as Lyme disease. What is your reaction to our teasing out the acute piece and only including chronic presentations as Lyme disease?
I can certainly understand how you would come to that, because it is almost like two diseases. There's the acute part and then there's the chronic part. So for the people who have acute Lyme that's treated early, they tend to do really well. And of course, we don't hear from them because they went back to work. But if you're talking about the chronic part, that's the really hard part. And I'm hoping that you did see the National Academies of Science report, which I think is really important, that the US National Academies sat down and they said, is this real? Because often Lyme disease has been called the aches and pains of daily living, which that really makes me mad. So they said, no, it's a real disease. And then the take home message there is, it's a real disease. We need to learn more about it. And we need to start treating it, even if we don't understand everything there is to know about it. That there's no reason we can't treat Lyme disease from multiple different directions. If the people get better, you have to keep all that data. And then you can say 10 years from now, this is what we learned.
So but I think you're actually making our point about why we are defining it only as a chronic disease and not as an acute disease, because one of the reasons why many doctors are trained to believe that it's not a real disease is because there is this merging of a chronic and an acute presentation. And because there's a merging of a chronic and acute presentation, and because they've been trained to deal with only acute illnesses, we have an acute illness system. And because, as you had said, most people who come in with an acute presentation and they are given antibiotics, they go away. And so the argument is that it's easy to diagnose and easy to treat and easy to resolve is true at the acute phase. So that's why we tease it out and say, nope, that's not Lyme disease. That's borreliosis, anaplasmosis, babesiosis. It's those things, but it's not Lyme disease, so that we can get away from this gaslighting that's taking place, not because doctors are bad people, not because they don't want to help people get better, but because of the way they've been trained. And when they now look through this prism of their training, they think it's something that's simple to treat when it's not, if it's a chronic disease. So we get out the acute and it's only chronic. So give me your reaction to that piece, or debate with me about why we're wrong to only have the chronic presentation.
No, I think you've carved off a really important part. And I would say that the other thing to keep in mind is, if you have an acute disease and you go to the doctor gives you your antibiotics and you get better, you have no reason to go back. But supposing you don't get better, so you go back. The doctor says, there's nothing the matter with you, don't bother coming back. Well, then you're not going to go back, are you? You're going to go find another doctor. So I think that's part of this, is that there's this reinforcing cycle. You only go back to a doctor that you think is going to help you. If the doctor said they're not going to help you, you're not going to go back. That doctor doesn't know that you actually stayed sick because you never went back.
Okay, no, fair. Let me give you another piece of the chronic argument we make, which is one of the things we've learned from Dr. Rawls and Dr. Phillips, for example, in studying their work and interviewing them on our podcast or different platforms, is that at least they argue, based on their experience in treating people in the Lyme community, that it is very rare for a patient to go from a tick bite to a chronic presentation. And I think what's interesting about the parallel arguments that they both made in their books, at least, is that the two circumstances where they've observed clinically someone going from a tick bite to a chronic presentation have been when somebody has been bitten by multiple ticks at one time. I mean, they trip into a nest and they get multiple tick bites, and then they get sick. Or you have somebody who's living in a moldy environment, for example, where they're immunosuppressed, they suffer tick bite, and now they get sick. Other than those two circumstances, and they both argued it's very rare, there's generally a long period of time between a tick bite and a chronic presentation. So I think part of the reason why we stay away from the acute piece is because we want to make sure that we're teasing out the gaslighting that's happening when doctors believe, or different diagnosticians believe that that it's easy to diagnose, it's easy to treat, because acutely it is. But part of the reason we want to make this argument is because if somebody's coming to you with a tick bite, or somebody coming to you with a presentation after a tick bite, it's very unlikely that you're going to get chronically ill anyway, because it seems that there has to be some period of time where your body becomes toxic before you become chronically ill. There seems to be a window of time, and we think the best way of dealing with that is by changing the definition and making it only chronic because of that observation. Give me your thoughts on that.
Yeah. Well, I'm just going to say, as a kind of ballpark figure, that you would call it acute Lyme for up to about a year. And then after a year, it's going to be chronic, right? That I don't think you would get very many people who had, you know, Lyme disease, the borreliosis. If they have it for very long, then it's going to have disseminated throughout them, and they're going to have all sorts of problems. You know, they're going to have neurological problems, cardiac problems, arthritis problems, all these things.
Yeah, again, I've never thought about it. I'd like to explore this with you. I wouldn't, my reaction to you arguing that an acute presentation would be less than a year, I'm not sure that I would agree with that. So my unwashed response is that I think an acute presentation would be weeks, maybe a couple of months, but I think if you're sick after that, I think it's chronic. I just don't think illness for a year would fit within my definition of what an acute presentation is. What do you think?
Yeah, well, I'm going to say that I do know people like linesmen who will be working in places where they can't do a careful tick check. And they seem to do okay for about a year, and then they fall apart, and then they're incredibly sick.
Yeah.
And they often will say, I just wish I had gone earlier. So that's why I was using the number as a year, because an otherwise healthy person can sometimes tolerate the infection for a remarkably long time.
Yeah, yeah.
Yeah.
So give me your thoughts on the next piece of our definition is we have a post-infectious presentation, right? So we have chronic infectious, all about our definition, the way I'm give me your thoughts on the infectious versus post-infectious elements of our definition. And do you think Lyme disease can only be an infectious disease?
No, I think Lyme disease can definitely trigger other things. So I think that I would say that you treat for, I don't know, maybe a year or something like that with antibiotics. And there are a lot of people who, after that point, don't seem to make a lot of progress. So you do need to start thinking about other things. So I would say minimum of a year, maybe 2 years, that's up to you and your doctor. But if after 2 years the antibiotics aren't helping, then you do need to start looking at other possibilities.
So let's talk about antibiotic treatment after a tick bite. What is your perspective on that as an earlier intervention tool, and what kind of antibiotics do you think are generally the best to prevent an acute presentation, ultimately becoming a chronic presentation of the disease?
Yeah. Well, first of all, you need to look where you are. And where I am in Alberta, about 20% of the ticks have Lyme disease, of the Lyme ticks. So if I'm walking in the river valley and I find a tick and it attached and I removed it right away, I would say I would watch. Careful watching and waiting, but I would test the tick. If the tick comes back negative, which in this particular case it probably would, then I would say, okay, I'm going to be careful. And, for the next month or so, I'm on high alert. If I get any kind of flu-like illness, straight into the doctor. But if I were in a place, like Lyme, Connecticut, and I got bitten by a tick, I would make a very different, risk-benefit analysis. And the reason I say that is you don't want to upset your microbiome needlessly. So if you didn't have any particular reason to believe this was likely, I would say I don't particularly want to take antibiotics. So this is where you would really have to look at the entire environment that you're in. And to me, testing that tick is going to be the biggest piece of information that helps me make that decision.
So let me ask you about the tick testing. And we do advocate for tick testing. In fact, on our website, on Tick by Blueprint, we actually list some labs that we recommend that people consider using. But, the CDC in the US does not recommend tick testing. And their argument is, and I'd like your reaction to this, is that they don't recommend tick testing because the tick that is being tested, microbes that have not been spit into you, and you may have the microbes spit into you that are no longer going to be in the tick. So is there really a lot of value to making decisions based on what is presenting in the tick from the tick test?
I would say absolutely, because you can argue that you're never going to know the whole truth. It's true. We don't know, did the tick actually transmit, which is the whole issue with the mosquitoes, because I think mosquitoes rarely actually transmit. I think that you're crushing the entire mosquito, you're picking it up maybe in the gut, but it wasn't going to transmit it through the salivary gland.
Right.
So I think you can say that if that tick, though, tests positive, and I found that tick, what about the tick I didn't find? It says that I'm in an environment where if I got one tick, what about the nymphal tick I missed? It might have been
That's a
in my
great,
hair. It might have been
great
somewhere
argument.
else.
Great argument. Yeah, no, I like the argument. So yeah, I think it's look, we strongly advocate for people testing their ticks, and I think it is a data point that you have to consider. And you're making another great argument that I hadn't heard made before, which is that if you're in a tick endemic community and the tick that's being tested is testing positive for a particular microbe, it's likely you were bitten by other ticks, and it's likely those other ticks would have harbored that same microbe. So I like that argument. I'm going to steal it from you, and I will do my best to remember that you were the person that taught it to me, so I can footnote you. So, one of the other things I want to share with you, and I know Matt is getting frustrated with me because I'm loving our conversation, and he's sitting there.
I'm enjoying it as well, actually. So this, you generally get mad at you, Rich, but I'm really enjoying this dialogue. But I do want to jump in at some point and talk to Janet about all the other CanLyme stuff. So we'll get there, though.
I promise. Give me a couple more areas that I want to discuss with my new friend, and then I promise, Matt, we can let you get into CanLyme. So we have a formula, a risk formula that we borrowed from General Stanley McChrystal. He wrote a book entitled Risk, and what General McChrystal argues in his book Risk is that the risk of something happening is formulaic, and that the risk of getting Lyme disease, for example, or contracting Lyme disease the way we define it, is threat times vulnerability. So what we're always looking to do is look at the threats, look at the vulnerabilities, and then bring that together to define risk and overcome the risk of you becoming sick from Lyme disease. So let's talk about those two pieces in the context of the conversation we were just having, which of course is, now the risk is, if you're in a tick endemic community or you're in a place where you're more likely to come in contact with ticks, you have to be aware of those ticks. You have to be taking precautions to prevent yourself from coming in contact with ticks, and you have to, of course, take steps to make sure that you're checking for the ticks and properly removing them, right? But then we have the other piece of this, which is the vulnerability, right? And what is causing us to be more vulnerable, right? And of course, part of what we want to make sure that we're doing, especially when we're living in tick endemic communities, the way Matt and I are certainly living in tick endemic communities, and we have ticks on our dogs all the time. I find ticks on me all the time. I mean, it's just something that we are constantly dealing with, and I have, quite frankly, done it for almost all of my life. Have been dealing with coming in contact with ticks. What I have to also do is make sure that I'm not vulnerable, that my immune system is healthy, that maybe I'm taking some precautions prophylactically to put myself in a position where when I do come in contact with the tick, that that my immune system can respond robustly, and I can take some other natural steps when I find the ticks, so that I can be more confident with not taking the antibiotics and not interfering with my gut health. Give me your thoughts on our use of the risk formula, and what thoughts do you have on what we can do to protect ourselves prophylactically so that we don't have to rush to the antibiotic response every time we get bitten by a tick.
So I think it's important, as you said, to have a mental model, which is what I'm seeing as your little formula. And in your mental model, I would put you, like your particular history, I would put the environment you find yourself in and all these things. So I do like the idea of having this kind of little formula. It's a good way of just trying to remember that you're part of this formula, the tick is part of the formula. In this case, it's the reservoir animals. It could be chipmunks, it could be birds, it could be anything like that. So it's important to put all those little factors in. So the model.
The rodent population, right?
Yep. Yep. And then I do think that when it comes to just as any human being, eat well, sleep well, plenty of exercise. Those are the three obvious things, and they are the three hardest things to do. We all know that. I mean, if we all did that, we'd probably be a lot healthier. So I think that there's no question, if you're being very careful with yourself, you're taking every risk factor that you possibly can, reducing the rodent population, all this stuff. Yes, I think you probably could go with some of the antimicrobial herbals, right? So you would talk to somebody who's a specialist in this, but I would say you wouldn't necessarily leap to antibiotics right away.
So one of the things that Matt and I have done, because we live in tick endemic communities, is in addition to making sure that we are focusing on our sleep so that we'll be healthy, focusing on the quality of food that we're eating. And it's very difficult, right? We have a lot of processed foods available to us, and it tastes good and it smells good and it's salty and sweet and we really love it. But we get
and the parasites make us want to eat more sugar rich. Come on,
Yeah. And of course getting movement and moving. So, but in addition to that, we actually take the Restore kit from the Vital Plant, Dr. Rawls's tool. And the reason I decided to take the tool, even though I've never had Lyme disease, is because one of the first times after we started this podcast, I had gotten bitten by a tick, not the tick bite that triggered us doing this passion project, but right after that, I had gotten bitten by a tick. And I consulted with Dr. Casey Kelly, brilliant doctor. She did a great job, and she was strongly recommending antibiotics. And it was something that I considered and actually ultimately used, right? And then I got bitten by a tick, and then I started studying Dr. Rawls's work again, and he was talking about prophylactic protections and not wanting to be on antibiotics all the time. And I got bitten by a tick again, and I actually consulted with Dr. Rawls. I did a consult with Dr. Rawls, and because I had been taking the Restore kit, and because I was knock on wood, relatively healthy and had been focusing on these elements that you had just pointed out, I decided that I was just going to use the Restore kit as the tool. But I was doing it in anticipation of getting bitten by a tick, and doing it in anticipation of putting myself in a position where I would be able to have a good outcome without having to take antibiotics and deal with all the side effects of the antibiotics. So give me your reaction to what I did and what my thought process is. And again, we're not doctors and making recommendations to any of our listeners, but just give me your reaction to the approach I had taken the second time as opposed to the first time.
Yeah. Well, the only problem I have is money. Like, if I knew you had the money, I would say go for it. But if I knew that by spending money on this, it prevented you from getting good food, doing whatever else needed to be done, that would be my big concern. So as long as I know that it's like you're not going out to eat and you're using the money you would have spent on fast food, I would say 100%. I have no problem with that. But it is a problem when you live in a situation where you really are extremely constrained. That's where it's going to be hard to say, could you justify that amount of money?
Yeah, but I don't think it's particularly expensive, and most of us who are living in North America can afford to focus on those types of prophylactic tools without it really having an impact on our lives. And you're right, there are some people that are living in difficult in difficult situations, but I think it's pretty rare in North America that you can't come up enough money to pay for the Restore kit. I just think that's pretty rare, especially when you're doing it prophylactically, where I'm taking actually half a dose rather than the full dose every day. If it's costing me $100 a month, Matt, I don't even think it's that much. I don't think.
Well, it's a little bit more than that.
But remember, I'm only taking half, so I'm buying a kit every other month.
Right. I think, yeah. So probably in that ballpark. Yep.
So I want to explore one more thing before Matt jumps in, and again, I don't want him to be choking me over the Zoom. Matt and I have actually written a book. We haven't published it yet, but we've written a book. And the book that we've written is based on another formula that we've observed, and we believe that the best way of preventing yourself from getting sick from Lyme disease is using the ACRE formula. A is avoid coming in contact with ticks. And obviously some of the ways you would do that would be by making sure that you understand where ticks are and avoid where they're going to be. Or if you know you're going to be coming into a place where there are going to be coming in contact with ticks, making sure that you're using proper precautions, whether it be natural or chemical, to repel the ticks. Then the second step in our framework is check, and learning how to check properly and when to check. Our argument is you should be checking twice a day: in the morning when you're getting dressed, and at night before you go, you change and go into your pajamas, assuming people are not sleeping in their clothing, right? And using your fingertips as a tool for checking rather than your eyes. And of course, partner checks are an important part of that as well. Um, um, then, of course, learning how to properly remove the tick, which is the R. Part of that is, of course, saving the tick so that we can have it tested the way you had advocated for earlier. And then we have early intervention steps, which are the steps you're going to take from the moment that you have, the tick has bitten you, all the way until about 6 weeks later, where you're constantly monitoring, how you feel physically and emotionally, and even spiritually, and tracking that whole process, where we have a number of different steps in our blueprint. So give me your reaction to our ACRE Lyme disease prevention formula.
I like it. I like the idea that you're looking at it over time too, because I think it's easy for people to sort of look for a simple black and white answer, that you're saying that if I do this, I've solved my problem. Well, you haven't. So with these complex problems, I really like the idea that you've put this sort of temporal element into it. You're saying, here's what I do right away. But even if I did everything right at the beginning, I'm going to have a certain number of things that I'm still going to keep my eye on towards the end. And so the only thing maybe you could add to yours would be, reach out for further information. That's the only thing.
Okay. Yeah. So and actually our framework, we actually ask you to actually think Lyme many years into the future. So our temporal timeline is not just the 6 weeks where you're really taking step by step by step, and we have a whole bunch of steps that we recommend that folks utilize during that window. But even after that's over, because the chronic presentation in many cases is a long time after a tick bite, that you have to think Lyme probably for the rest of your life, because there are going to be many presentations that are going to look like something like MS, and a doctor may diagnose you with MS when it's really Lyme disease, or there could be an element of a cancer diagnosis, or a dementia diagnosis that's really Lyme disease, or it's at least an element of Lyme disease, right? So we want you to always think Lyme after you've had that experience. So we believe it's sort of a lifetime timeline rather than that short timeline. So any other input into the ACRE formula? I appreciate the first observation. You're teaching me so much here, Janet, which is why I don't let Matt ask any questions.
No, I just really like the idea of giving people something like with a little set of sort of a flow chart. Just kind of go through and say, well, where is my little checkpoint? At what point am I going to say, yeah, maybe I better go back revisit that. So I like the idea. It's a wonderful framework for people to have nice and easy. Put it on the refrigerator. When you come in the door after a good hike, you're hot and sweaty, you can say, what are the parts I need to think about right now?
All right, cool. Well, thank you. So, all right, Matt, I'm sorry I went down so many different rabbit holes with Janet, and I have many more I'd like to go down, but I will now wind down so you can jump into a bunch of what you're asking.
It is all good. So, Janet, what I really want to talk to you about is your CanLyme not-for-profit, right? So Canadian Lyme Disease Foundation. You do a lot of cool things there. So obviously you're the president, right? And you're featured on their website. That's how we got in touch. But you also have a podcast too, which you have a good amount of episodes. You have 70 episodes, right, through CanLyme. And, it's really cool to have you on here to kind of collaborate, to kind of help spread awareness even further than the scope of the CanLyme community here in the States, right? But talk to us about, if you can, just why you formed CanLyme. And I know there's a little bit of a personal touch here. You kind of hinted on it earlier, and, how it evolved.
Sure. So CanLyme was founded by Jim Wilson. And Jim Wilson's story is that he was in Nova Scotia, so way on the east. He gets bitten by a tick. He ends up getting Lyme disease, and he's moving all the way to British Columbia. So he gets to British Columbia, and by the time he gets to British Columbia, he's really sick. Now, fortunately, his wife was able to help, and his wife managed to get him the treatment he needed. But then his daughter gets sick, and she got sick in British Columbia, which is the other end of the continent. So Jim said, okay, it's time to do something about this. So actually, Jim is the founder. And then I didn't know really much about CanLyme. When my son was sick, we didn't know it was Lyme disease. But everybody kept saying, if nothing else makes sense, you have to think of Lyme disease. And so that's why we had gone through all these diagnoses, and a certain number of them were just, you're going to die anyways. So let's sort of cross them off the list, right? We can't do anything about it. But the one that kept coming to the top all the time that was actually treatable was Lyme disease. So we said, we want to treat for Lyme disease. If the kid gets better, fine. If the kid doesn't get better, we can go back and we can revisit all these other diagnoses, but they're very depressing diagnoses. Let's not start with that. Let's start with Lyme disease. So we treated him as though he had Lyme disease. He got better as though he had Lyme disease. We're happy. We're just going to call it Lyme disease. So I spent a year after he finally got better. He was very, very sick for a long time, but eventually gets better. And then I got on the internet and I was kind of poking around. And that's when I met Jim. And I saw that Jim had already created this beautiful foundation. He already had a lot of people working on it, including one of my buddies, Ruben Kaufman. So I go down the hall and I knock on Ruben's door and I say, hey, Ruben, what's this with Lyme disease? And he goes, oh, yeah, he's a specialist on tick feeding behavior. And he goes, oh, yeah, that Jimmy's a good guy. I said, great. So then I contact Jim. And so that was about 2007 when I first met Jim. And then I got more and more involved. I joined the board in 2009. And then I became president when Jim was ready to step down.
Wow. So so my first reaction to the beginning part of that statement is, we often hear that Lyme doesn't exist in Canada, right? But yet here he is. It's on both sides of the continent, right? The west and the east coast of Canada. And, okay, we got to do something about it. So clearly it exists. That's an interesting part of your story. But now when you get involved and you become president, tell us the cool things, I guess even before that, tell us the cool things that CanLyme does. Obviously on your website, which is canlyme.com, you have a lot of information. But what are some of the cool things you offer, not only from a resource standpoint, but from a product standpoint and an assistance standpoint to, just everybody in the world, not only Lyme patients?
Right. Well, partly because of my training as an entomologist, I said, really what we need to do, we can put our finger in the dike or we can try to change the system. So Jim had already got a lot of contacts throughout various levels of government, which is wonderful, because I think the government at a certain point knew they had a problem. So they were getting a lot of very hard line, Lyme is easy to diagnose, Lyme is easy to treat, but they kept seeing that that doesn't exactly work out in real life. So he had these contacts, he was working with contacts. I helped to write some, more sort of scientific outlines about why I believe what I do, sent them off to the various levels of government. We ended up actually getting a bill called C-442. So we actually had an MP who helped us, private members bill. We were really proud of ourselves. A lot of work went into that. We get this through the system and they say, great, okay, here is $4.1 million and you can't have any of it. Because if you want to come and join us, you have to agree that Lyme is easy to diagnose, easy to treat, and all these other things. And we said, but That's not Bill C-442. Bill C-442 is, we recognize there's a problem. We recognize that the people are sick. And what we're doing right now isn't working. So we decided that, yes, we can focus on acute Lyme. That'll stop the problem from getting bigger. But we still have to do something for the people who have the chronic Lyme, the people who were missed, you know, in the 1980s, in the 1990s, all these people, like there's this lag time of people who are sick. And they've become a very large number. We don't know exactly what the number is, but we know it's a very large number. So that's what we really wanted to get to, is some sort of way of helping the people with this long Lyme. But it never actually came to be. We don't have any improvement in guidelines, things like that. Now, I'm hoping that because the American National Academies has said Lyme disease, the long Lyme, they're calling it Lyme Ayaki, but that is real. I think we're going to get some positive feedback at the level of the government now. And then I thought, see, the Canadian healthcare, each province has its own healthcare, and we have the federal healthcare. So my thought was, because I live in a low endemic area, I would focus federally, which is why with Jim, it's a federal organization. And I kind of hoped we could be farther ahead than we are right now, but it's still a bit of a slog.
Well, you've made a lot of progress. So I'm going to speak to some of that just from knowing what I've learned about you to prepare for this interview. But can you repeat what you said it's called in the States? Because I thought it was called post-treatment Lyme disease syndrome, or PTLDS is what we call it. So what did you refer to it as?
Yeah, the National Academies said that because it's so contentious and everybody just keeps shouting past one another, they said, let's call it Lyme infection associated chronic illness, Lyme Ayaki.
Huh.
And I thought, good. Now, it's just odd enough that you're going to remember it. You're going to have to think about it several times to get it stuck in your head. But I thought, yes, let's just try to see. There's no sense shouting at each other anymore. We've tried that, didn't work. Let's say that we know that people are sick. We know we can identify them. I also appreciated within this report, there was this feeling that there are different types. There are subtypes. And I think that's important because there's no one size fits all. For some people, it's, you know, they respond really well to one treatment, and other people respond well to a different treatment. So let's try to see if we can take some of the subgroups and maybe focus on them and find out what works for them.
That's great. Yeah, and just to speak to some of your accomplishments, I mean, you know, reading up on you guys, you're, as an IT person and an IT professional, I loved reading up about how you guys are supporting user-friendly access to tick data in Canada. You know, we have a similar thing in the States, but tell us more about that, how we can use data to make sound decisions in Canada pertaining to tick-borne disease.
Yeah, well, we have to thank one of the people who was working with us, and that's Sarah Cormode. And she said, why don't we take the tick infection data from a small private company called Genetics. So this is a company in Ontario that tests the ticks. And if we would pay to put it up on the internet, you and I can go and look at that map and take a look. If all of our neighbors are finding positive ticks, we need to know. If none of our neighbors are finding positive ticks, that's also useful information. So we decided that we were going to put a lot of effort on that. And you can see that the number of ticks submitted clusters, and it's really quite obvious when you take a look at where the positive ticks are being found. And so if I go to Southern Ontario, I go to Quebec, I go to Nova Scotia, New Brunswick, and Manitoba too, I'm much more concerned than I am here where I live in Alberta. We have lower numbers for sure.
Yeah, and what I love about the visual, so anybody wanting to see this is on your website again, CanLyme.com, and you have a map embedded on this little news article, and you can open it up in a large screen, and you can see how certain parts of Canada, it looks like on the east coast, and then there's a little bit of a gap, and then to a little bit to the west of that, and then a little bit more on the fully west side. But you can see the gaps where it's like crazy concentrated with all these reports of, you know, Borrelia species, and it's data driven. It even has a species of Borrelia, right? Borrelia miyamotoi, Borrelia, you know, Bergdorferi, Anaplasma, Babesia microti, Babesia duncani, right? So it's really neat to see the ticks, the diseases, the pathogens, and the concentration on a map. it helps the brain easily understand where the higher risk areas are based on these reports. So really cool, really, really cool map. And I love that. So just had
Can I
to,
tell you, what I want to do next, right? What
yes,
I
do
really
it.
want to do is I want another layer to this map. And on this layer of the map, we take all the reported cases in dogs, for example.
Ooh.
And we put that as a layer, and you could look through. And then as it gets darker and darker, you say, whoa, the dogs are getting it, the people are getting it. And then we put another layer on top of that, and that is cases of unexplained illnesses. Do they map? I want to know. You put
I
them
think
on.
they would, and I think you're onto
I
something.
think we'd be onto something. So I'd like to see a multi-level map, not just the ticks, but have this multi-level map. Multiple layers on top of each other, and then start to look through and drill through on that.
That would be so cool. You guys have to do that, and you have to share it with us, and we will share it with everybody. Because I mean, I really think the clusters of unknown, mysterious chronic illness will be very much directly correlated with these high incidence of tick-borne infections, and they're just misdiagnoses potentially, right? So that would be a really interesting data analysis to do, and then visually see it on a map would be so cool.
Yeah, and then even if it's not true, I think that would be cool. That would mean we got to go and figure something out. We're making assumptions, and we need to actually have some data to make, to pull this together. Yeah.
So talk to us about, because I'm on your website, I'm just clicking around, right? And you guys have done a ton of other work too. And you do a ton of research-driven work, meaning you collect funds from various people, businesses, et cetera. And as you're not for profit, you're taking that money and you're giving it for direct research for people to study Lyme disease. So can you share with our listeners some of the research you funded and some of the cool work that those people are doing to help advance our knowledge of Lyme and tick-borne disease?
Sure. Well, some of the early work was to just say Lyme disease is real. And I'm going to sort of use as an example, people in New Brunswick were told, we don't have the tick, don't worry about it. Well, that's crazy. They live right beside Nova Scotia and they live right beside Quebec. Like, you can't tell me that they don't have Lyme disease. So the nurses then would do a little research project. They would say, when you tested positive, why do you feel you have Lyme disease? What are the reasons for that diagnosis? Everything like that. And then try to see where the system is falling down. Now, I think it's pretty clear that the testing, which they have changed and they continue to change, the testing is really the crux of the matter. So we really want a better test. We're not there yet, but I think that's the first thing. So we try to, the testing the ticks is easy. It's pretty straightforward. So I think we've been there, done that. Now we can go on to the people. We need better testing for the people. We need better ways, like just the one paper was a child had Lyme disease. He was told he couldn't have Lyme disease. And then they just wanted to interview him and see what are the long-term costs of being gaslit and things like that.
That's wild. So, but I mean, I'm just going to kind of highlight some of the bullets because, I mean, it's really cool what you guys are doing. So not only are you helping the patient population and those kind of studies you just described, but you also supported the formation of the Mount Allison Research Network, right? And you funded many research projects through your venture grant program at them. You also have, I mean, this is really neat. You developed a test for detecting Lyme infection in animals, including horses, mice, and ducks. But that same technology and those tests that you funded could be eventually elevated to the human population. You've established the prevalence of Lyme disease bacteria in cows and the possible transmission in milk, which is really interesting and fascinating, right? You discovered, the preferred micro habitats. I don't know why I struggle to say that. You discovered the preferred microhabitats of questing ticks, those looking to attach to a host. So can you share with us a little bit more about some of the findings of these research studies, or even just the coolness? I mean, they're kind of interesting studies, right?
Yeah, but right now they're basically pilot projects because we're not a huge foundation. But the idea behind the venture grants is let's let people, give them enough money to get started, especially if they can train a student. Because a student then will carry on and continue throughout their career, keeping in mind that Lyme disease is real. So these ones are still just, pilot projects, but they're out there for somebody who has more resources to be able to extend further.
Nice.
So basically, we're just trying to say this is your venture capital, as it were. Here's a little bit of money, put it to work. If you find something cool, put it out there. It needs to be out there. So now we can go back and we can see how much we can apply that elsewhere.
So cool. The last thing is, and this is definitely, Rich's wheelhouse. So talk to us about the research where you're investigating the relationship between traumatic stress and the persistence of Lyme disease, because that's huge. I feel. I think Lyme makes you stressed, and I think the stress keeps you sick, and I think it's a vicious cycle. And I think that's super common in chronic Lyme disease. Can you even share your own personal thoughts or anything you've done in that research area?
Yeah, no, exactly. Well, we're funding that research, which is still ongoing. But I think there's absolutely no question that there are a lot of people, unfortunately, who are traumatized. Like they might get better from the Lyme disease, but they're so traumatized by the experience that they are afraid to go back to the doctor. So now we've got a double problem. They maybe got better from the Lyme disease, but they're so traumatized, they're not going to the doctor. So maybe they're going to have another diagnosis, which is going to get missed. So that's the big concern there. I also think that when the doctors, perhaps they don't realize how traumatizing it is. But, I had the one guy who said, my son would not be sick if his mother would go and get fulfilling employment. And it's kind of like, I'm looking at this doctor and thinking, that's absolutely insane. How can you talk to me like that? So I think we all get, and anybody who has Lyme disease has stories like that, where you just think doctors need to realize that they're traumatizing patients when they deny the absolute facts that are sitting there staring at them.
Yeah. Richard, you want to weigh in on that?
Yeah, no, I mean, it does sort of circle back to the conversation we were having earlier, which is doctors, unfortunately, are looking through a prism based on the frameworks that they were taught when they were in medical school. And I really believe the biggest problem that we have in this community is a definitional problem, which is why I spent so much time, and I really enjoyed our conversation with exploring our definition for Lyme disease, because I believe in my heart of hearts that if our definition was adopted, the likelihood of a diagnosis substantially increases, and I believe the likelihood of gaslighting and the impact that that has on the stress level of of a patient would be substantially decreased, right? It's the vulnerability piece that we were talking about in the risk formula. Lyme is very good at creating stress and creating a toxic environment in the host. And when you're adding to that gaslighting from the medical community, it does really substantially increase the likelihood of illness and substantially increase the length of time of the chronic illness.
Yeah. I also want to highlight, because we absolutely love the University of Rhode Island, who, they're, and also anytime somebody gets bit by a tick, I'm like, you'd be silly to not take a photo, submit it. They get back to you generally in a day, right? And they tell you the tick ID, how long it's been attached to you, what its life cycle is, this whole comprehensive report that you can save and just kind of file away and bring to your doctors in case you ever need it, save the tick, et cetera, right? But what is cool about their website is they have all these tick ID charts to identify common ticks in America, right? But when you get into Canada, the common ticks are a little bit different, it seems like. So what I like about your website is, and I never knew this until preparing for this interview, you have common ticks in Canada, and it's very similar to the University of Rhode Island's Tick Encounter Resource Center and their website, but it's for Canada. So we're going to certainly refer people in Canada to your website now, because it's such an easy to view and comprehend webpage you have about common ticks in Canada to identify the ticks, but not only identify the ticks, but what to do if you're bit by a tick. So Rich and I absolutely love this, right? We have our own tick bite blueprint on our website, which is basically a step-by-step guide of what to do if you're bit by a tick. But the identification is a key part of that. URI helps a lot in our area, but this resource guide is key. So let's talk a little bit about the tick removal process, because your website has a really good guide there as well. And to be candid, I think there's one piece I'm going to steal from your website, because we crowdsource ours. So ours is basically just acquired from all the interviews we've ever had. But I think we're going to take a little bit of your website and integrate it into ours for our step-by-step guide of what to do when you're bit by a tick. But what's really neat is you kind of tie it all together: the tick ID, the tick removal, and then also the tick removal kit. So I'm really fascinated by the kit that you guys have on your website. Can you tell us what went into that and how you then sourced and identified what was key to go into a kit to remove a tick bite?
Yeah. Well, we sat around and we thought, as an entomologist, I always carry those fine pointed tweezers. So all entomologists carry them anyways. But we thought, well, maybe most people wouldn't. So that was one of it. The other thing is, if you've ever tried to remove a tick from a squirming child, you can't come up to them with fine pointed tweezers and say, here, sit still, I'm going to remove a tick. So that's where that little plastic scoop comes in really well. And the same as like the ear of a dog. If you have that little plastic scoop, you can scoop it in and then pull the tick out gently. So we decided those two were key. We needed to have some sort of way. If you're out in the woods, you're going to say, oh my God, what do I do now? So we've updated our kit now, and you have a little QR code and it'll link you back to the website so that you can at least get some positive feeling like, yes, I did it right. But then the other thing, people seem to really like fine pointed tweezers with a little magnifying glass too. So you can reach in, grab it and look through and say, yes, it's a tick. So this is something that, we've worked with the Magnata Foundation, the original tick kit. We worked with the Magnata Foundation on, and again, they're doing research for Lyme disease. And now we're partnering with genetics, who do the tick identification and the testing of the ticks.
Yeah, so I was going to ask you that because it's really cool that you have the 3 style of tick removers for various use cases, because there's a lot of different scenarios out there with different age people, as you noted. So talk to us about Genetics. So it's Genetics, because I think that's basically a tick testing company in Canada that you guys recommend, because we have a lot here in the States that we like. But in Canada, it'd probably be costly to ship and back and forth. So is Genetics a tick testing company you recommend to the people that follow CanLyme?
Yep. We recommend them because it's also social enterprise, which means that they're not just for profit, that they want to, the man who founded it had Lyme disease himself. So we recommend. The other part is he gives us the data. We have access to that data. So we have access to the data, which is why you can build that map and see where in Canada are ticks testing positive. So there are some other companies that are coming up, and they're interested in getting into more tick testing, but we don't have the same relationship where the information flows back and forth. And that's the important part. And I think just knowing that the information is there for public use is just really critical for you and I.
Yeah, no doubt. It's not just testing the tick, but it's sharing that data to aggregate large scale data to help inform and advance the cause, right? So it's really more than just testing the tick. So what are some other things that CanLyme does? Because obviously you touched on a lot of them. Just give us, what did we miss? Tell us a little bit more about CanLyme and any of the things that I may have missed in my questioning.
Yeah, basically education is a big thing. So we want to have the doctors better educated. Right now, if you went to medical school, 10, 15 years ago, you were probably told that Lyme disease, nah, don't worry about it. So we want to make sure that the doctors realize that it is a very important and difficult diagnosis. We want to educate doctors. We want to educate the public so that they know if they go to the doctor and the doctor says, we don't have Lyme disease in Canada, right? They can say, no, we do have Lyme disease and you do need to take it seriously. We do have a certain amount, like we've got just an amazing team. And I want to make sure that everybody understands that I'm just the president, I'm the figurehead, but a lot of the really hard work is going on behind the scenes. So we have a lot of people who are working at trying to do the awareness in a way, as you said, that the website is excellent. And, I can't say enough good things about the man who runs our website. Sherwin Arnott does an amazing job. So he works really hard. We do a lot of bouncing ideas back and forth. And then the media have been wonderful. Like I'm just amazed at how, with mostly when you talk to the media, they understand the problem. Like it doesn't take them long to catch the idea that something has been missed and this something is an identifiable problem. So let's get to work and fix it.
Yeah, I mean, there is so many cool things on your website. The one thing that I also love is, and I know you don't host these support groups, but networking and finding somebody who is going through or has gone through a similar experience to help kind of guide you through it is key. And you have a get support section on your website. And again, we don't know a lot of this because we have a lot of the American side, but not the Canadian side. So we're going to recommend your website again because you have so many contacts and groups in Canada about Lyme support groups and Lyme resources that are just in-person meetups or virtual meetups, which is really neat as well. So how do you source that And how do you find all these people to aggregate and ensure that they're good, they're a real legitimate group that you want to get behind to sponsor,
That's the really hard part. I would say, actually, in many cases, those groups are just getting exhausted. And especially after COVID, when, it's that post-COVID that people have been working so hard for so long. And so I would say that's a weakness right now. So we do need a better way of actually supporting patients. Right now, we have to basically outsource that to the other, the provincial groups or the more local groups. And I just wish that, we had more people willing to answer the phone, that there's a huge need out there. There's a huge need for people to have their reality actually understood by other people.
So my final question before Rich picks it back up is I have to ask, because it's what I've been saving. There's an article on your website about machine learning algorithms to help predict tick-borne pathogen risk across Europe. And I'm really excited about the advancement of AI. It's also scary, but I'm more excited than I am nervous. But I'm really excited about that because I do believe it's going to help us in so many areas, including health and wellness, and including specifically the tick-borne disease world, right? So the fact that you guys are already jumping into that space, which I think is so cool, what are your thoughts about current technology and future technology in helping this chronic Lyme community, especially around machine learning, algorithms, big data, AI, et cetera?
Yeah, I think that it's huge just because we need to have something where there's all sorts of patterns, but we're just getting overwhelmed when we're looking at them. And the machines can come by and they can start picking it out. It doesn't mean they're right. That's the important thing is they give us an idea, then we have to then go back to the data and say, if this is true, then this is what we think is the best explanation. So by no means do I think they're going to put us out of business. The machines are really limited in what they can do, but they can produce a hypothesis for us to go out and test.
So, Janet, let's tie this up by talking a little bit about the Canadian medical system and the American medical system, and what we can do to make changes in the two systems. And one of the things that we had hoped before we started interviewing Canadians was that the path to treatment would be easier because you have a socialized medicine system. And there are many people in the U.S. who believe that the reason there are so many challenges with getting treatment in the U.S. is because we don't have a socialized system. Well, as it turns out, with all the folks we've interviewed from socialized systems, whether it be the Israeli system, which seems to be the top, or maybe the co-top socialized medical system with Canada, and all of our European guests, that it turns out that the problems that you have in your systems are even greater than ours. And a lot of people seem to be coming down and treating in the U.S. Because of the limitations that are associated with the socialized medicine system. So, can you first give us your perspective on the challenges that Canadians faced when they do become chronically ill from Lyme disease, and what kinds of changes do you think need to be made in order to make sure that people get better outcomes when they're treating in that system?
Yeah. I think that fundamentally the system is good. So, for example, when my son was sick, we go in there, they eliminate all these other obvious diagnoses. It happens slower than in the US because in the US, you've got a lot of technology like right on the ground. So it's true, it maybe took us 3 months, something that would have taken 3 weeks if we'd had that same testing done. But once we hit that level, I didn't actually feel we would get any better treatment in the US than we would in Canada, with the one exception. And that is our system's a little bit slower, but it's good, it's thorough, the doctors are well trained. But they're also trained in a more like one view, that they had been to the same hospitals, they'd had the same training. They didn't have the diversity of training.
Same
And
framework.
I think Americans are better at tolerating mavericks. So I think you have a higher tolerance for maybe the doctor's overreacting, but yeah, whatever, he's a good doctor, let him try it. Here, they would kind of squash the doctor. So I think if we can get the system to recognize the problems, our system will change pretty quickly. because it doesn't have many of the same stressors. Like the whole idea of co-paying to go to the doctor, it's kind of like a Canadian goes, say, what? Like, you mean you're paying for parking? And I say, no, our big concern is paying for parking. And so I think our system could answer very quickly. Right now, again, post-COVID, the system is stretched far too thin, that we need more doctors, we need more nurse practitioners, we need more people on the ground. But I think that the fundamental system is a question of tweaking, not a question of tearing it down.
Okay, so one of the things you shared with us earlier is some of the legislative accomplishments that you've made and are continuing to work so that they can get to the point where they're real accomplishments. Is that the place where you have to go to ultimately reform the medical system? Or because it's a government-controlled system and a government-run system, if you can get the government to acknowledge a proper definition legislatively for Lyme disease, will that resolve the problem that you're having medically?
I think doctors are very sort of determined that they're right. So I think you could have a bureaucrat telling a doctor to do something and the doctor would just say, no way. So I think it's a multifaceted problem. We need pressure, so legislative pressure saying maybe it's Lyme disease, maybe it's something else, but the patient does need to be treated. That's important. And then at the same time, you're training all the doctors, they're watching the patients get better. Because to me, that's the thing that's so surprising. We all know people who were horribly sick. They got the right antibiotics, they got better. So you would think every doctor would go, wow, I learned something. So keep the data. So take a look at all these people who've been horribly sick, and our system should be able to spin pretty quickly. The moment that the doctors themselves say, I know that patient isn't just making trouble, that that patient really is sick. Let's see about the treatment for Lyme disease. Treat them for Lyme disease, they get better. Go tell your buddies about it. And then it just kind of, goes out through the system that way.
So the last set of questions we always ask our guests in this journey of achievement and journey of transformation is, how has this been transformational for you? How has all the work that you've been doing and all the help that and all the service that you've been offering to the Lyme community in Canada, how has that been transformational for you?
Well, it has helped me because my son got better. And a lot of people would say, oh, that's, how come your son got better? Did you have this like secret stash of antibiotics in the garage, or what did you do? Right. And I would say, no, I actually worked within the system. My son was actually treated in Canada. I worked within the system, and now I pay back by trying to help other people get the same treatment. So I think that's been a big part. It's sort of survivor guilt that you can say, I know I was really, really lucky. Now I need to share with other people who maybe weren't quite so lucky, and we'll help it go that way. But if I didn't do this, I'd be working on an insect that eats plants. I did not choose to work on Lyme disease. It sort of chose me, that I would be working on a pest insect and, trying to solve canola beetles, that kind of thing, and not even think about Lyme disease. So it's sort of changed my life that way. But I also like to say to my kids that they actually got to see, everybody knows parents don't give up on kids, but my kids got to see that firsthand. They got to see the parents keep trying, and you can slam the door in the face of that parent 1,000 times and they'll just go find another door. So that's the kind of the positive thing is, at least like my whole family just recognized we're not going to give up easily. This is a difficult problem, but we're going to solve it.
Janet Sperling, thank you so much for taking time away from your family and the great work that you're doing for CanLyme to share your great story and your great work with the folks here at Tick Boot Camp.
Thank you.